Good day and welcome to everyone. A special warm welcome to our out-of-state guests as well as our international attendees today. We have a great webinar planned for you today, and we're so thankful that you all joined us. As a reminder, these complimentary webinars are brought to you through a collaboration of sponsorship with Care Choices, Hospice and Palliative Services, O'Connor Mortuary, Caring Companions at Home, and Alzheimer's Orange County. And my name is Kim Bailey, and I'm a gerontologist at Alzheimer's Orange County, and I will be your host today. Our sponsors are providing these special topics as a service to the community. These are topics that are beneficial for anyone who works with or cares for a family member with some type of dementia, and as well as those who are working in the older adult community, excuse me. We know that you will find today's presentation informative and useful. Dr. Brian Hitt, and he's a board-certified UCI Health Behavioral Neurologist who specializes in the diagnosis and management of Alzheimer's disease and other cognitive and memory disorders. He earned his medical degree from Northwestern University's Feinberg School of Medicine in Chicago, Illinois. He completed both a neurology residency and a fellowship in cognitive and behavioral neurology at the University of Texas Southwestern Medical Center in Dallas, Texas. Dr. Hitt holds a PhD in cell and molecular neuroscience from Northeastern University, and he completed a postdoctoral fellowship studying tau protein seeding activity as a biomarker at the Center for Alzheimer's and Neurodegenerative Diseases at University of Texas Southern Medical Center. Dr. Hitt has conducted extensive basic research into the cellular and molecular mechanisms of Alzheimer's and related neurodegenerative diseases. His current research interests include bench-to-bedside translational studies to develop novel diagnostic and therapeutic ways to target the tau protein, which is involved in the pathology of Alzheimer's and several other neurodegenerative diseases. So we are very thrilled to have Dr. Hitt with us. We get great feedback from our families who see him, and he's been very generous with his time doing several educational presentations for us, including today's topic. So with that, I will turn it over to you, Dr. Hitt. Thank you for being with us.
It's my pleasure. Thank you so much for the introduction. So what I wanted to focus on in my talk today is the causes of dementia other than Alzheimer's disease. And this is a really, really common question that I get. And so I know that there's a lot of interesting questions in the community. And so I thought it would be kind of an important thing to raise some awareness of and kind of help you all to be more confident in, answering questions that family members have about kind of the distinction between Alzheimer's disease and these other conditions. I think there's a really good understanding in the community in general, and oftentimes Alzheimer's disease itself is talked about quite a bit in the media. So I think most people have a generally good sense of what Alzheimer's disease is, what it looks like. But I think it's often used interchangeably with the term dementia. And I think that, there's a lot of questions about, what is the distinction? Are Alzheimer's disease and dementia the same thing? Does one contain the other? And so I kind of wanted to go through definitions and talk about the other causes, what they look like, how they affect people's lives and quality of life, how we go about diagnosing them, and then kind of the anticipatory guidance that we give families as far as other symptoms that might go along with these conditions. There we go. So I wanted to start out just by defining dementia, because this is kind of the first area where I think there's a lot of confusion. I often have patients and family members coming to my clinic asking, expecting to be diagnosed with dementia, or asking, do I have dementia? But this is really something that is not a specific disease process. It really doesn't require a physician to kind of diagnose. This is really just a descriptive word. It's a word that we use to say that somebody has memory or cognitive changes that are more than what we expect for general aging, and that are enough to affect functional independence. And that's really the key thing. That's the dividing line between dementia and changes that are short of dementia, is whether they are causing you to need help from somebody else with your daily activities, such that you couldn't get by without help from somebody else, and that is because of memory and cognitive changes, and not from some injury or orthopedic issue, that it really is the cognitive changes that are causing you to not be functionally independent. This is something with a slow onset, a gradual progression, and that is more than just the normal cognitive aging that we do see. So there is such a thing as normal cognitive aging. In about our 30s, our processing speed peaks, and from that point forward, everybody experiences some decline in processing speed. It takes us more time, takes us more effort to do cognitively demanding tasks. It can mean that we, forget what we went into a room to do. We have memory and attention lapses of, having difficulty coming up with the right word to say, or somebody's name, eventually coming to it, but taking a little more time. And those things can be normal. So that's kind of the first question we ask when somebody comes in to see us is it more than that? And then there's a separate diagnosis that is what we designate as more than normal cognitive aging, but not quite meeting that criterion for dementia, and that's mild cognitive impairment. So if it's more than normal cognitive aging, but not yet affecting functional independence, the diagnosis that we use is mild cognitive impairment. When it starts to affect activities of daily living. And so the initial ones are things like managing your own personal finances, managing your medications, keeping track of your own schedule, calendar, appointments, arranging your own transportation, shopping and preparing meals. When it crosses that line to start affecting your ability to do those things independently, that's mild dementia. And then when it starts affecting the more basic things we need to do, like getting dressed, bathing, grooming, eating meals, using the toilet, that's what defines moderate and severe dementia. So once we answer that question and say, yes, we think there is a process here that's more than normal cognitive aging, the next question is what's causing it. And I think a lot of the reason why dementia and Alzheimer's disease are used so interchangeably is that far and away, the most common cause of age-related cognitive decline and of dementia is Alzheimer's disease. And so this is a kind of a chart put together by the Department of Health and Human Services that outlines the most common causes of dementia. And I, kind of illustrated that with what are the brain changes that happen that cause these. And so it's the whole purpose of getting to a diagnosis is saying, what changes in the brain are leading to these symptoms that are affecting people's lives and quality of life. And Alzheimer's disease really is defined by the pathological microscopic changes that we see looking through a microscope at a slice of tissue stained with certain stains. What we see is the amyloid plaques of beta amyloid and the neurofibrillary tangles of abnormally folded tau protein. And those are really what, when a doctor or a scientist says Alzheimer's disease, we're talking about that pathological entity that's really only definitively diagnosed on autopsy examination of the brain tissue. But we can say from our experience and from kind of, what we see following people clinically, that we have a high suspicion in somebody that is affected by that is showing signs of dementia, that it looks like an Alzheimer's disease type pattern. Alternatively, there are a number of other things that can cause dementia, the second most common being vascular changes. We'll talk a little bit about this. The second most common neurodegenerative process is something called dementia with Lewy bodies. And then there's another category of a number of different clinical syndromes called the frontotemporal dementias. And so these are kind of the main non-Alzheimer disease causes of dementia that we'll talk about each of them in turn here. And then I want to point out on this, you'll see that there's a number of slices here that are mixed pathologies. So Alzheimer's disease plus something else. And that's actually really common when we do look at brains of patients with dementia. It's really not uncommon to see more than one pathology. So I want to start by kind of briefly going over what vascular dementia and vascular cognitive impairment is. Vascular cognitive impairment is the preferred term because now we realize that it's a large, wide spectrum that's not just dementia, but also encompasses milder changes. You can have mild cognitive impairment to chronic vascular changes that happen in the brain. This looks a little bit different from Alzheimer's disease. Clinically, in Alzheimer's disease, the main thing that we see affected is short-term memory formation. And, oftentimes, at least early on, most other things are pretty intact, and it really is a memory predominant change. With vascular cognitive impairment, we classically see something called a subcortical dementia pattern, which involves apathy, decreased motivated behavior, a lot of decreased processing speed, even beyond what we expect with normal cognitive aging, and poor working memory, which isn't really memory formation function. This is more a function of how much information you can hold in your mind for a few seconds while you use it. These are changes that happen to the small blood vessels in the brain, and there's a lot of overlap in the risk factors of that and the risk factors for heart disease and stroke. So having had one of those, having those kind of vascular diseases in your family are major risk factors. Atrial fibrillation is a big one. And then the classic small vessel risk factors, 4 of them: hypertension, hyperlipidemia, type 2 diabetes, and cigarette smoking are all risk factors for these age-related small vessel changes. And I want to draw a distinction between this chronic ischemia that we're talking about and strokes. So all of this is ischemic damage to the brain tissue. But in the case of a stroke, this is a blocked blood vessel that causes ischemia all at once in a certain brain region with a sharp line drawn around it. In the case of vascular cognitive impairment, more often than not, it's chronic ischemia, which means it happens slowly and gradually over years, and it's due to changes to the smallest blood vessels in the brain. They get more brittle, they don't let as much blood flow through as we get older. Everybody has some degree of vascular changes in their brain as you get older, but some people have more than others. Some people a lot more, and enough to cause memory problems on its own. And this is what it looks like on an MRI. MRI is extremely helpful in identifying patients with vascular cognitive impairment responsible for their symptoms, because these changes do show up on certain MRI sequences very clearly. They look more symmetric than a stroke in the deep structures of the brain. The deep white matter is what these areas are called, often kind of more white and fluffy cloud-like changes rather than the sharp lines that you can draw around a stroke. So when somebody comes to us and they have the typical small vessel risk factors, have slow and gradual cognitive decline that doesn't quite look like Alzheimer's disease, we'll often get an MRI. Sometimes that gives us our answer right here of vascular dementia or vascular cognitive impairment. The next cause that I want to talk about is dementia with Lewy bodies. As I mentioned, this is the second most common neurodegenerative cause, meaning this is the buildup of proteins in the brain tissue causing slow and gradual damage, leading to the cognitive symptoms. And I have a few patients, these are actual patients with their names removed, to kind of give you a sense of what patients look like when they present to us in clinic. And so this first one is a 69-year-old woman who's coming in with the complaint of memory loss. But when we ask more specific questions, this is trouble with memory that's been gradual and progressive over the last 3 years. She has trouble remembering recent conversations, but in addition to that, she's having trouble finding her way around, getting lost in parts of town that really should be familiar to her, that she's kind of lived in and navigated for many years. And in addition to that, she's starting to need help with finances and with managing her medication. So we know that she meets the criteria for the definition of mild dementia. And she has a few other things going on, in particular, visual hallucinations for the last 3 months. She sees kids on her furniture, kids running around her house. These are well-formed. These are not kind of a vague sense of a presence. She can actually see these people who aren't there. They don't speak to her and they're not frightening to her. Over the past year, she's been walking more slowly, bent over, has a stooped posture, shuffles her feet when she walks, and also has more salivation and drools more than she used to. During sleep for the last 10 years, so before any of these other things started, she'll act out her dreams. She'll reach for things. She punches and kicks and has injured herself doing this as well. And so this is, kind of a classic picture of dementia with Lewy bodies. Dementia with Lewy bodies is something that's very closely related to Parkinson disease, but the main, kind of the major symptoms are cognitive and behavioral in nature. There's 4 diagnostic criteria typically that kind of clue us into the diagnosis of dementia with Lewy bodies. Not everybody has all 4, but these are the things we look for and the questions that we ask. The first one being fluctuating cognitive symptoms. So really good days, really bad days. And these are often with prominent visuospatial rather than memory formation and retrieval symptoms. So difficulty finding your way around, difficulty locating objects visually or finding things in the house, difficulty kind of remembering, what door to go in and out of, things like that. Attention, decision making can all be affected, even while memory is not. Memory does usually end up being affected, but it's a later change. Visual hallucinations is the second characteristic, and these are usually people and animals. These are usually very well formed. These are not just occasionally, they tend to be quite often. And it's for the same reason as the visuospatial cognitive difficulties. The main part of the brain that tends to be affected in dementia with Lewy bodies is the part of the brain that is very important in visuospatial processing. So knowing where things are in space, how they're moving, identifying them. And our brain is a very active thing. Our perception of the world is very active. It's not a passive video recorder. And so when it's getting inaccurate information and it's not processing your visual field in a really accurate way, it doesn't just leave a blank, it doesn't leave a black space, it fills it in with guesses. And that's where the hallucinations come from. The things that are meaningful to our brain are things like, furry animals, faces, people. And so that's oftentimes what it'll fill it in with. These are symptoms that we, don't always try to treat away. They're oftentimes not concerning and not frightening or disturbing to the patient. They can usually be redirected. They can be reminded by a loved one that, those kids aren't there, or, that they don't mean any harm. The third category of changes is Parkinsonian movement changes. So these are the same kinds of movement symptoms that we see in Parkinson's disease. We'll go over those in the next slide, but kind of the typical picture that we think of is the resting tremor, bent over shuffling gait, and slower movements in general, and then REM sleep behavior disorder. And so this is acting out your dreams, not being paralyzed when you're in the dreaming part of sleep. So there can be punching, kicking, running, reaching out. This doesn't include talking in your sleep. That can be a normal thing to do. Also, kind of jerking of muscles while you're falling asleep or while you're waking up happens to all of us at times. So that's not concerning. When we are actually kind of doing purposeful movements, acting out your dreams, that's not, that is abnormal and often goes along with these Parkinsonian syndromes like dementia with Lewy bodies. So with these four things together or in any combination, really raises our suspicion for dementia with Lewy bodies. So Parkinsonism encompasses a number of movement and non-movement symptoms that typically go together in this constellation of Parkinsonism. The classic resting tremor. So this isn't the kind of fast tremor in our hands when we're using our hands that all of us get if we drink too much coffee. This is a slower rocking back and forth tremor that kind of typically happens when patients are distracted or at rest. There's a slowing down of movements in general that we call bradykinesia. Postural instability, falls are really common. A slow shuffling gait, and limb rigidity, which is mainly something we pick up on our neurological exam, with difficulty relaxing the muscles. And oftentimes we can feel kind of a little bit of a tremor in that rigidity as well. Along with these things, there's often decreased blinking, decreased facial expressions, a soft voice, less emotional content in the voice, less modulation with emotion in the voice. Drooling is very common as well. And one thing that we definitely don't want to ignore is orthostatic hypotension, which is lightheadedness on standing that's because of blood pressure drops. And so, there's a reflex that causes our heart to pump a little stronger and a little faster when we're upright to get enough blood up, fighting gravity up to our brain. That reflex kind of diminishes over time, and especially in these Parkinsonian syndromes can diminish and cause this lightheadedness on standing. That can cause people to pass out, fall, injure themselves. And so there are kind of certain recommendations that we make to avoid that in our patients with dementia with Lewy bodies. So this is something that, is kind of notoriously kind of not well understood, not talked about as much as Alzheimer's disease in the community. I think that maybe has changed a little bit in recent years. And kind of one, prominent example of that is when the actor Robin Williams passed away, and on autopsy, the final diagnosis was dementia with Lewy bodies. It was a shock to many people, including his family. And his widow, Susan Schneider Williams, said that pathologist giving her that diagnosis was the very first time she had ever even heard of this diagnosis, even though her husband had been living with this for years, and it so profoundly affected their quality of life. So she's been kind of a tirelessly working to kind of raise the profile and also kind of support the research going into dementia with Lewy bodies since that point. The next condition that I want to talk about is actually a kind of a collection of conditions called the frontotemporal dementias. And this also kind of has had its profile raised just this year because Bruce Willis received a diagnosis of dementia with Lewy bodies, one of the primary progressive aphasia variants of this. This differs from the other things we've been talking about is in that these are generally young onset dementias. So the average age of onset is about 56, whereas for something like Alzheimer's disease, the incidence really spikes between the ages of 75 and 90. And so this is, This is substantially younger in onset, and actually 13% of cases are diagnosed before the age of 50. And so in somebody coming in with cognitive and behavioral changes at a younger age, this is always on our list of possibilities. It's kind of notoriously difficult to diagnose and to know how many cases we're missing, so it's really hard to estimate how common these dementias are. There's often a long delay before the diagnosis, and people come to us having been diagnosed with a number of different things, oftentimes seeing psychiatrists rather than neurologists for their symptoms. Survival rates after diagnosis vary, and there are a number of different clinical subtypes of this, and they can kind of progress differently. But in general, unfortunately, these tend to be fairly rapid in progression, more so than Alzheimer's disease, which develops over a decade or even more. These tend to have shorter survival, usually on the order of 5 to 7 years after diagnosis. So there's a number of clinical subtypes of frontotemporal dementias, and I'm really going to focus on the three main ones that are considered the classic subtypes of frontotemporal dementia. The main one, the most common one, being the behavioral variant of frontotemporal dementia, and then the other two are two different types of primary progressive aphasia, which is kind of slow and gradual decline in your ability to use language or some function of language. And there's two types: the semantic and the non-fluent variant of primary progressive aphasia. There's a third variant of primary progressive aphasia, which I'm not including here because it's no longer thought of as a frontotemporal dementia. It's a subtype, an atypical variant of Alzheimer's disease. The pathology is almost always Alzheimer's disease with that clinical variant. And then these other three are often kind of included under the umbrella of frontotemporal dementia. But I'm not including them here because, really the cognitive and behavioral symptoms do exist in these, but they're really not the things that are impacting quality of life. In the case of frontotemporal dementia with motor neuron disease, or MND, it's more of an ALS-like pattern of, loss of muscle strength. And in these other two, PSP and CBD, it's really a profound movement disorder, similar to Parkinsonism, that affects people's quality of life, although there are cognitive and behavioral symptoms. But I want to go over examples of these three main subtypes, starting with a patient example that illustrates behavioral variant FTD, where the main changes are behavioral and personality changes. So this is a 51-year-old woman working as a business executive, and very, very high functioning in her work life and in her family life, a lot of responsibilities. She comes in with 4 years of behavioral changes that are affecting her home life and her work performance. She's been telling higher ranking coworkers to pipe down. She's been belittling the appearance and the clothing of her support staff and not understanding why that's hurtful. She has a new obsession with sugary coffee drinks, a sweet tooth, and has kind of very profoundly changed her preference in kind of food choices. Has started to compulsively collect antique statuettes, spending on these exorbitantly. Has started to refuse to drive her daughters to their basketball games and says their teams stink anyway. Again, doesn't recognize why this is hurtful. And for Father's Day, she gave her husband a used cigar that she found on the ground, not understanding why that was appropriate or why that was inappropriate or why it was hurtful. And so the key features of behavioral variant frontotemporal dementia are kind of these changes in our social behaviors, in our personality, oftentimes a loss of motivation towards previous interests, so a lot of apathy, And then, as we can see, prominently in this patient example, loss of social grace, disinhibited behavior, and really prominently a loss of empathy. So not understanding, why the things that kind of disinhibited things that they're saying or doing are socially inappropriate or hurtful. And like the name suggests, a lot of the volume loss, a lot of the damage that happens in frontotemporal dementia, it's in the frontal and temporal lobes. So this is another case where the MRI imaging can really help us arrive at the diagnosis. If we see kind of a patient presenting with these kinds of symptoms, and we see that the MRI shows a lot of loss of volume, like we can see in this lower right corner, prominently in the frontal and temporal lobes, that's highly supportive of the diagnosis. Oftentimes when people come to us, it can be because of disrupted family relationships, marital discord, job losses, or not doing well at work. These are the things that can kind of make the difficulties rise to the level of seeing a physician. And oftentimes, this is the most common subtype of frontotemporal dementia, but it's not the one that I see most commonly. And I'm afraid that that's because more often than not, these patients end up presenting to psychiatrists rather than neurologists, and kind of end up being treated as such, which is, not the most evidence-based way to manage frontotemporal dementia. Along with those changes, there can be repetitive, compulsive, or ritualistic behaviors that develop. A sweet tooth is very, very common. It's the frontal lobes that tend to suppress those food preferences we have in childhood. So those kinds of things can come back, along with relentless overeating, not being able to kind of suppress that drive to eat. Temporal dementia, I want to move on to one of the primary progressive aphasias, particularly the semantic variant. And so we have another kind of example patient here. This time it's a 69-year-old woman. So these primary progressive aphasias do tend to be a little bit later in onset than the behavioral variant. So this woman is 69 years old, a retired secretary, and is referred for memory and behavior difficulties. The first thing that her family noticed was she was not understanding what words meant when they were said to her. And so would ask things like, what is a screwdriver? What is a buffet? When she was trying to come up with words, she would talk around them, like saying the round thing instead of pizza. Also, it wasn't just the words themselves, it was having trouble understanding what objects are, what they meant, how to use them, would reach for the ice cream part of an ice cream cone rather than the cone part. Also starting to have trouble recognizing faces, even of familiar family members, and even herself in photographs. She stopped being able to do household chores, kind of forgetting how to do those activities. And she started to need a really fixed and rigid daily routine. She became quite inflexible, self-centered, and her personal hygiene declined as well. And so this is an example of semantic variant primary progressive aphasia. The things that tend to be prominent early on are losing word meanings and also kind of object meanings, facts like you learn in school. It's kind of a loss of semantic knowledge, really, rather than use of language itself. It's kind of that that knowledge base that you build up over your life that starts to decline in semantic variant PPA. And the first words to go are uncommon words, but as the disease progresses, you can forget the meaning of even common words. And similar with object knowledge, forgetting what kind of less common objects are, and then kind of forgetting kind of how to use more common tools and things like that. Usually, at least early on, grammar and speech sound production are usually okay. Pronunciation is okay, can speak in full sentences, just have a lot of difficulty accessing that dictionary of what words mean, and kind of facts and knowledge. This is another area where structural imaging is really helpful to us. In these primary progressive aphasias, the classic thing that we see is an asymmetric pattern of volume loss or atrophy, with the left side of the brain being much more affected than the right side. Our language functions in the brain tend to be lateralized to the left side of the brain. And so the classic pattern that we see in the semantic variant is that the front part of the left temporal lobe is where we see most of that volume loss. And that is kind of where a lot of those semantic functions tend to rely on the most. Really not uncommon to have behavioral symptoms similar to what we see in behavioral variant FTD, along with the semantic variant of primary progressive aphasia, like this patient does show. And this patient also exhibits some difficulty with visually recognizing objects, and particularly faces. And oftentimes that correlates with the degree to which the right temporal lobe is affected, especially recognition of faces is, there's a gyrus, an area on the bottom of the right temporal lobe that's very specifically tuned to recognizing faces. And so as that loses volume, there can be a decline in ability to recognize faces. The last subtype of frontotemporal dementia is the non-fluent agrammatic variant of primary progressive aphasia. And this is really the classic inability to speak, inability to get words out, difficulty in speaking fluently. And so there's a progressive loss of fluency. There can be, even early on, fairly hesitant or halting speech. They can make grammatical errors early on, so leaving out function words, today, very sunny outside, dropping the endings of verbs, so they are have a picnic instead of having, and they can make errors in subject-verb agreement. There is often kind of mispronunciation, poor articulation, problem with speech planning, the motor part of speech. And there can be a difficulty in comprehension, specifically with sentences that have grammatical complexity. And so it might be just fine for them to understand a sentence like, the tiger killed the lion, but if you phrase it, the lion was killed by the tiger, they might have a difficult time answering the question, which one of them is still alive? That's kind of what things look like early on, but really as the disease progresses and really kind of a year or two into progression of symptoms, patients can progress to the point where what it really looks like is, if they have something to say, they get very frustrated, red in the face, very frustrating to kind of have something to say and kind of not be able to get the words out. And oftentimes it quickly progresses to not speaking in full sentences, just little words at a time, and difficulty getting their thoughts expressed generally. Again, we typically see a volume loss pattern that's asymmetric, affecting the left side more than the right side, and that's illustrated here. Here's kind of some of those speech and language symptoms that we can see when we examine the patient. So a lot of difficulties finding the right word, a lot of difficulties pronouncing, so there can be stuttering. Circumlocutions are when you're talking around the word, so not being able to find the right word, and needing to kind of describe it instead. Mispronunciations like fort instead of fork, things like that. Because the left side of the brain is affected more than the right, and because the left side affects the right side of the body, we can see slow and clumsier movements in the right arm and right leg along with this as well, that before we get the imaging can kind of clue us in that this is what we're dealing with. So in terms of when somebody is coming in with cognitive complaints, and we have a suspicion for some non-Alzheimer disease form of dementia, I oftentimes expand out the exam that I do. And so I'm going to talk about kind of some of the things that I do, in exam to, try to look for objective corroboration to, some of the subjective things that we talked about that family might complain about. And so I, have a few different things that I do to examine language and visuospatial processing. The first one that examines both of those things is having them describe a scene. And so this is kind of a classic one that's been used for decades now. Not surprisingly, it's a kind of outdated looking scene, but this is called the Boston cookie theft picture. It's part of the stroke evaluation when somebody's having an acute stroke in the hospital. We try to see how well they can speak by having them describe this picture. But it gives us a chance to examine a few things. So how fluently can they speak? If we have them describe it and they're not able to describe it in full sentences, there's a decline in fluency. Are they able to name, a number of different things, or do they really have difficulty finding the words for the things that they're seeing in the picture? And then as far as visuospatial processing, are they able to put together the whole scene that they're looking for, understand what's happening, understand why the things here are, a problem or are strange? Or can they really just zero in on little individual details and not put the whole scene together, which is a symptom called prosopagnosia, or simultagnosia is the neurological name for a difficulty in kind of putting the whole scene together. In addition, I have patients name certain items, and I'll use sets of items where I can see what their naming is like, but then also whether they're able to categorize by semantic category. Can they group these items by what category they belong in and explain why they belong in that category? And then similarly, I'll have them name these items and see if they're able to group them by what we call phonemic properties. So by similarities in the way they're pronounced. So, how good is their understanding of kind of how the sounds map to the meaning? And so can they name these, but then can they identify items on here that rhyme with each other, like boat and goat, or that start with the same sound, like boot and bone? And so, that gives us a sense of kind of their phonemic, which is a very important kind of part of fluency. I'll also kind of test object knowledge, showing them pictures and asking them what they would use this item for, or when might they need or use this item. And that gives us a sense of semantic knowledge and abilities. And then I have a few kind of ways that I test for visuospatial function. So in kind of line drawings where they overlap, patients with visuospatial processing difficulties can have, a difficult time teasing out individual items and can kind of just see a jumble of lines, and not be able to identify the individual 4 items in this picture, which is known as the Poppelreuter probe for visuospatial dysfunction. This is called hierarchical figures, which are shapes making up other shapes or letters making up other letters. In a patient with simultagnosia or a difficulty putting the whole picture together, oftentimes patients can see the small figures, the small images, but not be able to see that they're making up a larger image. So they might report that they're seeing plus signs or stars, but they're not seeing anything that looks like a heart. Or they might say that they see the letter H, M, and T, but they don't see the letters E, A, and M. And similarly, we can kind of show a picture of, smaller things making up a larger thing. And so like a patient that I saw earlier this week that had visuospatial deficits, could name kind of all the different fruits and vegetables they saw in this picture, but couldn't recognize that this was a portrait, that it was kind of making up a person's face. And so that kind of gives a sense that integration of visuospatial information is not intact. In addition to the examination, oftentimes we want to get further corroboration with with extra tests. And so one thing that's available to us is biomarkers testing. This is when we're trying to answer the question, is this Alzheimer's disease or something else? And the lumbar puncture to examine spinal fluid biomarkers to kind of look for changes in the proteins in the spinal fluid is really helpful in answering the question of Alzheimer's disease or not Alzheimer's disease. So we won't see any specific changes in dementia with Lewy bodies, frontotemporal dementia, or vascular dementia on this, but it can kind of, if we think it's Alzheimer's disease but doesn't quite fit the usual picture of it, if it's somebody who's coming in, younger with things other than memory that are affected first, this can be really helpful. And there are two changes that happen on the y-axis here. It's the A beta 42 level, which A beta 42 forms the plaques. When there are plaques forming, it sticks in the plaques and doesn't make it into the spinal fluid. So it's lower on this chart down here. And then the second change that happens is the phosphorylation of tau protein. And so that can cause the phosphorylated tau to increase. So when we see the A beta 42 go down and the phospho-tau go up in the spinal fluid, that's consistent with Alzheimer's disease. Anywhere else, and it's, we need to consider other conditions. This is an example of an FDG PET scan. This is a PET scan that looks at where the brain is using energy and where it's maybe using less energy. And this kind of helps us distinguish the pattern of Alzheimer's disease from especially frontotemporal dementia. The patterns can look quite different in where the brain is kind of quieting down. And so this is kind of the test of choice when we're trying to decide between those two diagnoses, although dementia with Lewy bodies can have its own particular appearance on FDG PET as well. And then when we have a suspicion for dementia with Lewy bodies, when we see the movement changes, but we're not quite sure if it's Parkinsonism or just kind of age-related slowing down or things like that, we can get a DAT scan. And this is looking at specific populations of dopaminergic neurons that decline in Parkinsonian syndromes. And so this area called the basal ganglia that's shaped like a comma, when we look at the tracer uptake, where those dopaminergic neurons are, can go from looking like a comma to a period. And it's usually asymmetric as well. So you can see in this case, this left basal ganglia has declined in size even more than on the right. I want to talk a little bit about kind of the reversible causes, things that are not kind of the progressive irreversible causes, because these are things we don't want to miss and can sometimes look like dementia. So in the past, the main things that we would talk about as far as reversible causes were infections like syphilis and HIV, but with the ubiquity of effective treatments for those, that's really gone away. And also, vitamin deficiencies like vitamin B12 deficiency can cause memory difficulties, but most people's diet is perfectly sufficient in vitamin B12 these days. Everything tends to be fortified. So that's a really, really uncommon disorder. What we can see is cognitive impairment secondary to mood and anxiety disorders. And the classic one is post-traumatic stress disorder, can cause a lot of difficulty with thinking and memory, but really any kind of mood and anxiety disorder can cause inattentiveness, distractibility, memory lapses, and difficulty with decision making. So this is something we always want to be on the lookout for, because management of those psychiatric symptoms can improve the cognitive symptoms as well. Another thing that we really don't want to miss is cognitive impairment secondary to a sleep disorder, and particularly obstructive sleep apnea. This is extremely treatable. We can see people have a tremendous turnaround in their quality of life with effective treatment of OSA. And so, when people come in and there's, memory complaints, but also there's some snoring, there's some daytime sleepiness, we always want to make sure the workup includes a sleep study to make sure this isn't a problem with insufficient deep sleep at night. newer on our list of possibilities, and this is also something that is not progressive, not long-term. It's the cognitive changes that happen secondary to a viral infection, particularly a respiratory virus. We've known about these because there's, a kind of post-influenza cognitive symptoms that people can get, but it's been really, really common after COVID-19. And so there's usually a delay in it, but when someone's coming in with some new symptoms and maybe a couple months earlier had a COVID infection, it could be one of these kind of short-lived neurological symptoms that come in the post-viral period. These usually resolve on their own after 6 to 12 months. So really what we want to do is identify that that's what's going on and reassure the patient. The most common things that we see are anxiety and difficulty with expressive language, stuttering, difficulty getting words out, and poor concentration or brain fog. So that's another thing that we kind of keep our eyes open for in patients with new cognitive symptoms. And I just want to finish by mentioning that, for those of you that are local at UCI, we do a lot of important research, including studies where we're looking for healthy individuals over 60 to try to kind of follow over time and see what kinds of things predict age-related changes and signs of neurodegeneration. So I put up some information for the Beacon study here and the website and the number that you can call for that. We also do clinical trials. I also see patients at 3 different clinics here at UCI Health, and the phone number for those clinics is up at the top there. And so I will finish with that, and I think go back to the sponsor slide.
Okay, great. Well, we do have a number of questions for you, Dr. Hitt, and I'm watching the time because I know you have to leave in 7 minutes. And so I just really quickly want to thank our sponsors again before we turn this back over to you. O'Connor Mortuary, Secure Choices Hospice and Palliative Services, Caring Companions at Home, and Alzheimer's Orange County. And to remind everyone to save the date of our next webinar on June 13th. We'll have the topic is hoarding disorder, understanding and treatment. And that will be presented by Krista Tipton. Okay, let me get into the chat box and see what we have.
I see some really good questions. I can stay a little over as well to make sure we can get to all these.
Okay.
I see a lot of kind of really important and great questions. I just saw asked if donepezil helps Lewy body dementia. Absolutely, and that's actually kind of one of the other defining characteristics of it. While medications like donepezil, the cholinesterase inhibitors, can help a little bit in Alzheimer's disease, and that's its primary indication. Oftentimes in dementia with Lewy bodies, there's a pretty brisk response of the cognitive symptoms to medications like donepezil. So it's absolutely indicated, at least a trial. Also saw mentioned a question about Pick disease and what type of dementia that is. That's a frontotemporal dementia. And so that's specifically a change of the tau protein. It's different from the tau changes that happen in Alzheimer's disease. And oftentimes the clinical syndrome of Pick disease is a frontotemporal dementia. Let's see.
They were also asking, you were talking about treatments. What about treatments for vascular dementia, Dr. Hitt?
So we often use very similar treatment approach in vascular dementia using the medications like cholinesterase inhibitors and also memantine, which is kind of a second cognitive enhancer medication that we use in patients with cognitive impairment. But in addition, it's really important in patients with chronic ischemia to work closely with their primary care physicians to manage small vessel risk factors. So high blood pressure, high cholesterol, blood sugar, if that's a problem for them. Diet and exercise is really important to pay attention to as well.
Great. Another viewer is asking what dementia do we associate hypersexual behavior with?
So that can be seen in
And
any.
paranoia, sorry.
Yeah, so that can be seen in any of the dementias, particularly late in the disease. But if it's an early symptom, the thing that we think most about is dementia with Lewy bodies. Also, one of those kind of movement disorder, frontotemporal dementias that I mentioned before, PSP can often be associated with those kinds of behavioral changes, hypersexual behavior, paranoia. Obviously, behavioral variant can have any of those kind of behavioral changes as well. So behavioral variant, FTD, and dementia with Lewy bodies are the ones that would be highest on my suspicion.
It's interesting talking about hypersexuality because you mentioned already that it can take years to get an FTD diagnosis. And I know that several of the people in our FTD Lewy body support group got divorces because they've been seeing psychiatrists about hypersexual behavior, affairs, etc. Even molestations of relatives have happened in the support group. So thank you for making that important. Yeah, it's tough. It's painful.
Yeah, it tends to be a difficult symptom to treat as well. And there's a lot of controversy in, kind of what there are not a lot of medications that are evidence-based and show a lot of evidence for being effective. The main thing that we do is going to use the SSRI antidepressants for their side effect, essentially, of decreasing libido. But there's a lot of controversy about whether there's an indication for hormonal treatment. So essentially chemical castration in certain circumstances.
Thank you. And just a reminder to everyone that we do have this caregiver support group, especially for caregivers of FTD or LBD. And that's available on the first and third Tuesdays of each month. And so let me know if you have questions about that. Here's a question about orthostatic hypotension in a patient who has Lewy body dementia. How is that what is that and how can that be treated? Briefly.
Yeah, excellent question. So when we see orthostatic hypotension, which is that blood pressure drop when standing up, the first things that we do are conservative measures like making sure patient stays well hydrated, making sure they're not eating a low salt diet. Not enough salt can kind of make the fluid not stay in the blood vessels where it belongs. And then things like compression stockings or abdominal binders to make sure that there's not pooling of blood in veins. When it's kind of pooling in the veins, it's not available to pump up to the brain. And so those are the things we start first. And then if we need to, if they're still passing out with those measures, there are a couple medications that we use. Mitidrine is usually the first one that we'll start to keep the blood pressure a little higher, around the clock, essentially.
Okay. Dr. Hitt, is there a correlation between tinnitus and dementia?
There isn't. And tinnitus is something that we see very, very commonly kind of across the board and get a lot of questions about it. And there's still no effective treatment for it, but it's peripheral. It's kind of caused by the cochlea and the inner ear itself. It's not a central nervous system problem, not anything happening in the brain. And there are a number of treatments that are being investigated for it. So kind of stay tuned to see how those clinical trials go.
Okay, so again, you said there is a correlation.
Is not a correlation.
Is not. Dementia. Thank you. Yeah, thank you for clarifying. What role do hormones play in brain health? For example, loss of hormones associated with age and menopause.
Yeah, absolutely. So this is something that has, our understanding of it has changed quite a bit in the last few decades. And there was, kind of one of the things that's been noticed, for quite a while is that Alzheimer's disease is more common in women, even adjusting for the fact that women live longer. So at any given age, Alzheimer's disease tends to be more common in women. And we wondered if it was something having to do with the hormonal changes of menopause that, made people particularly prone. There was research that went into whether hormonal replacement could, mitigate the risk of Alzheimer's disease. There's promising data early on, but the conclusion ended up being no. And around that same time in the early 2000s, there was concerns that hormone replacement therapy could increase the risks of cancers. And so the pendulum swung back the other way. It's since swung back more or less to the middle where, it's kind of talk to your doctor about it. There are certain indications, but it's not something that's, either indicated for everybody or something that everybody should avoid. So there's kind of very specific circumstances in which it can be helpful.
Thank you. And speaking of risk mitigation, can you recommend any prevention practices to people with a family history of dementia? I know this could be a whole workshop.
Absolutely, yeah.
A lot of these questions could.
Yeah, this is another entire kind of 60-minute talk that I have. The evidence-based things that we know are preventative or protective for cognitive function and memory. The big four are regular physical activity, staying socially connected, and other activities that kind of keep your brain active. And the kind of key things there are novelty. So things where you're learning new skills or new information, things that you do with other people are the kinds of activities that tend to build resilience in your brain. So physical activity, cognitive and social activity, and then good quality sleep. So definitely making sure that you're not getting inadequate deep sleep at night, treating sleep disorders if they're there. And the fourth one is managing stress and anxiety, because we know that high circulating levels of stress hormones is fairly toxic to the brain, can age the brain faster. So those are kind of the big four preventive mechanisms. I'll just say briefly, because I know that, the question is out there with that. What about diet? It's been studied very, very extensively. It looks like, what you eat or what you don't eat has very little to do with your risk of dementia.
Wow.
Healthy diets tend to be the best,
Okay.
Diets that are healthy for the heart are best for the brain, but it's a small effect.
That's good. That's very interesting to know. Thank you. What medication do you consider to be best for sundowning?
Sundowning, the first thing that we start is early evening melatonin. It's kind of a little neurology trick that's kind of building some support in the literature, but we've known kind of anecdotally for a while that in addition to helping as a sleep aid, melatonin can really help kind of calm things down in the evening. Doesn't knock you out or make you sleep too early. It can just kind of make things go more smoothly in the evening. So we'll usually start it depending on when a patient's bedtime is and when their symptoms tend to start. You will give it at 4 or 5 p.m. And important to note that sometimes sundowning is kind of used the term is used kind of inappropriately or misleadingly. This isn't just kind of worse memory symptoms or confusion in the evening. This is getting upset, frustrated, agitated, not cooperating with care in the evening. And so, that's kind of the main, when we're treating sundowning, those are the symptoms we're trying to treat, is the agitation symptoms. Other kind of behavioral therapies, we, try various prescription therapies, but it's usually ones that you take daily to try to prevent the agitation rather than something you take right now to treat the agitation. We try to avoid the sedating medications that you take as needed and only use those in kind of really kind of desperate cases.
Thank you. Are you good for a couple more questions?
Yeah, absolutely.
Okay.
I can stay for a few more minutes.
Okay. Let's see if I can pronounce this. Is blepharospasm a type of symptom of dementia?
It is not. So blepharospasm can be a movement disorder. Blepharospasm is, often hard to differentiate that from blepharal twitch. Blepharal twitch is something that we all get. It's when our eyelid kind of, twitches and we can get a strobing effect. What the ophthalmologist will tell you is that's, a pretty common and normal thing to happen. And what they often recommend is warm, wet compresses for 15 minutes at night, every night, until that goes away, because it's usually a function of kind of irritation, blocking of tear ducts, things like that. But blepharospasm can be a movement disorder, and it's kind of forceful closing, involuntary forceful closing of the eyelid that does not have a specific association with dementia, but it would be treated by a neurologist. And so be important, if that's something that doesn't go away with conservative measures, to see a movement disorder specialist for that.
Okay. What is the root cause of Lewy body dementia?
Lewy body dementia is caused by a buildup of the protein alpha-synuclein, and this is the same protein that builds up in the brain in Parkinson disease. But in the case of dementia with Lewy bodies, it affects different parts of the brain, particularly the cortex. So it can lead to not only the movement changes that you see in Parkinson disease, but the cognitive and behavioral symptoms of Lewy body disease. So the Lewy bodies themselves are intracellular aggregates of the protein alpha-synuclein, which, like A beta and tau protein, is a protein that tends to misfold and stick together and causes problems in brain tissue.
Thank you. Does it make sense? The question is, does it make sense to remove a patient from their antidepressant medication when they're in late stage / hospice?
Ooh,
Yeah.
you ask enough providers, you'll get so many different questions to this. So, this is often a discussion between geriatricians, neurologists, and psychiatrists, and hospice physicians. And it depends on the patient themselves. If there's any suspicion that there are side effects at all, we can kind of slowly come down off the SSRIs. But if it's a patient that has had behavioral symptoms in the past that have been well controlled with the SSRI, I'm usually not in a hurry to get patients off of SSRIs, even in hospice care, because it's a really low risk medication typically, and you oftentimes don't want to risk a rebound agitation, anxiety, or depression in a hospice patient. And so I usually like to rock the boat as little as possible. And if someone's been stable on an SSRI, my preference is to keep it going. Even though SSRIs, the way we use them generally is not as a forever medication. The idea is to get symptom, get symptom resolution, and then eventually try to wean off of the SSRI. But in hospice patients, my inclination is generally to kind of not change things too much as far as the behavioral medication.
Great. Thank you, Dr. Hitt. One final question I think we have time for is, how early can you detect the changes associated with dementia, whether it's protein accumulation or vascular changes?
We'd like to get really, really good at detecting the protein changes before there are, symptoms. But, whether we're there, is kind of debatable. And so, we have kind of higher order imaging tests that we can do, like the amyloid PET scan is something where we can indirectly, you'll hear people talking. I strongly disagree with this wording, but saying that they're detecting plaques and tangles in living people with these PET scans or the CSF biomarkers tests. These are indirect tests that kind of tell us, probabilistically how likely those Alzheimer-related changes are to be happening in the brain. There are patients that are biomarkers positive that do not yet have significant symptoms, and there are entire clinical trials that are being done specifically in just those people. But more often than not, we don't do the tests until people come to us. And right now, that's as it should be. I don't advocate, I don't think it would be good healthcare to put people through those scans, across the board without any symptoms at the moment. It's just kind of too much. We already spend too much on healthcare. I don't think that would be helpful for us at this point. And as far as the vascular changes, sometimes we can see it really depends on kind of where the ischemia is. Sometimes we can see, ischemia building up on MRIs before patients have symptoms. But again, usually we're getting those MRI scans because patients have cognitive symptoms we're trying to explain.
Okay. Thank you so much to our wonderful presenter, Dr. Brian Hitt. We appreciate your time and your expertise. And for everyone, just a quick reminder that as we end the webinar, which we're getting ready to do now, the survey will open up immediately. We appreciate your feedback, and it is required if you are asking for a CE. Again, our next topic is going to be hoarding. That date is Tuesday, June 13th. For more information about all of the other wonderful educational classes and programs provided by Alzheimer's Orange County, please visit our website at www.alzoc.org. And thank you for joining us today. And we look forward to seeing you next month. Thank you again, Dr. Hitt.
Thank you. It's my pleasure.
Good day, everyone.